Thank you to the organizers for the invitation to be here and to contribute to this meeting, and even more importantly, thank you to the organizers for bringing all of us together and have a chance to interact in this very stimulating forum. My disclosures, nothing relevant for this presentation. So what I'm going to cover very briefly in the next 20 or so minutes is a background about this disease, brain cancer, glioblastoma specifically. But I think it's important to keep in mind, although this is focused on that tumor type, what we are coming across here is probably very relevant to a number of other solid tumors, particularly those that have proven relatively refractory to immunotherapy to date. And then highlight one of the reasons for that challenge and difficulty related to the tumor microenvironment in this disease. And then talk briefly about where we're going or what's happening in the field with cellular therapies, with an update on some of the CAR T-cell work that's recently been published and described, as well as a potential project we are putting forth to move forward with tumor-infiltrating lymphocytes, or TIL therapy. So for those who are not familiar with brain cancer, it represents a relatively small percentage of all cancers, 1.4%. But it is amongst the most aggressive and characterized by a high mortality rate. In fact, it now has become the number 10 cause of cancer-related death for both men and women, and the number 1 cause of cancer-related death among children. It's been rated as the number 4 cancer in terms of years of life lost. And unlike other cancers, breast cancer, leukemia, where great strides have been made in the last 10 years and remarkable improvements in survival have evolved. Today in my clinic, I'm still offering patients a standard of care therapy that was developed nearly 20 years ago and associated with a very low percentage of patients who are 5 years and almost non-existent patients out 10 years from their diagnosis. So we desperately need better therapies, and this, I think, certainly qualifies as an unmet need in current medical oncology. There's about 13,000 cases in Europe per year, same in the US and I believe in mainland Asia, probably more. It's a tumor that can happen at any age but does increase in frequency as we get older. And unlike other aggressive cancers, for reasons that have yet to be understood, this cancer does not systemically metastasize. It starts and stays in the brain, but it is incredibly infiltrative and invasive within the brain, starting out as a nidus and then moving outward and destroying basically what is in its path as it expands. We know patients who are older, who have other comorbidities or poor performance status, or have unresectable tumors, have a poorer survival. And if you happen to be over 65 or 70, have a performance status of 60 to 70, and have an unresectable tumor, you're probably looking at a less than 6-month survival here. If you're younger, 40 to 50, and have a better performance status and a resectable tumor, you may live 1.5 years. But these are still considered incurable and very challenging tumors. Now, while we've struggled in neuro-oncology to improve outcome, immunotherapy, as we've heard about at this meeting and others, has transformed how we treat many cancers today in medical oncology. And the history goes back to many landmarks, but one of them being the work pioneered by William Coley, a sarcoma surgeon, who made the observation astutely that his patients who developed infections after their sarcoma surgery lived longer than patients who didn't, and he began to introduce infections post-operatively in his patients after he resected their sarcomas for this reason. He didn't make the connection, and we didn't understand, of course, the immune system back then, but that was the idea at the time, and the field kind of languished for several decades. And then with the discoveries of the how the immune system is normally physiologically regulated to downregulate when it's activated so that it doesn't keep going indefinitely and doesn't cause off-target side effects by the expression of physiologic expression of immune checkpoint molecules, and the discovery of how these molecules are upregulated in cancer as a strategy to protect the tumor and suppress the anti-tumor immune response. We began to see remarkable responses like this after a single dose of immune checkpoint therapy for large melanoma lesions, and an unprecedented tail of the curve for survival in a disease that had been essentially uniformly fatal, typically within about 6 months, metastatic melanoma. And this slide I do need to update, but currently there are probably close to 90 approved immunotherapy indications in the United States for various immunotherapy approaches, including vaccines, cellular therapies, and checkpoint inhibitors. And work attributed for this, certainly recognized by the Nobel Prize for Professors Allison and Honjo in 2018, and my colleague Gordon Freeman, who also has contributed significantly to the understanding of the checkpoint molecules and their role in many cancers. So that's been remarkable and transformed medical oncology, but many solid tumors, including glioblastoma, have failed to respond to these immunotherapy approaches, including checkpoint inhibitors, and this is a series of 6 phase 3 trials that have enrolled close to over 3,000 patients, and unfortunately, all of these trials in this indication are negative to date. And trying to better understand why these approaches have been negative so far, I think leads us to an understanding that's evolving of the microenvironment of these tumors and what is characterized as a myeloid cell dominance and immunosuppression. This is a multiplex immunofluorescence of a typical glioblastoma tumor, and the red cells, which are, there's one here and I think another one here maybe, are quite few and far between. The tumor cells are in blue and dappy, and then the yellow cells are myeloid cells, macrophages, and you can appreciate how dominant the microenvironment is with these myeloid cells. This is an inherently low immunogenic tumor with a low mutational burden, low PD-L1 expression, and what I think is a perfect storm of multiple complementary mechanisms the tumor has put in place to exploit and protect itself from immune cell infiltration and activation. Multiple cytokines and molecules secreted by the tumor contributing to this, and then this dominance of the myeloid suppressive component. And then in brain cancer, we do also have to consider an iatrogenic component, because to decrease inflammation and associated symptoms related to cerebral edema, when tumors are active and growing, we often have to give patients corticosteroids, potent corticosteroids like dexamethasone, which also can provide an immunosuppressive component. So to focus on the myeloid cells within these tumors, like most organs, there is an intrinsic population of myeloid cells in the brain and the CNS. We refer to them as microglia, the normal physiologically present myeloid population in the CNS. And then the other main source of the myeloid cells we see dominating these tumors comes from the bone marrow. And these are trafficking into the tumor based on cytokines released by the tumor, that then attract the myeloid cells from the bone marrow into the tumor. And these myeloid cells, once in the tumor, are kind of hijacked in terms of their program. Instead of physiologically being there to clean up and remove debris, they are subverted to have a very immunosuppressive role to help support the tumor. And very briefly, to summarize in a single slide, a lot of work and ongoing effort to better understand this symbiotic crosstalk between the myeloid cells within the tumor microenvironment and the tumor cells. A variety of factors going each way, back and forth, to support one population supporting the other and vice versa. So we do know, although these tumors there's a prominence of these myeloid cells, the ones that have a higher percentage highlighted in the red curve here in this graphic showing a poorer prognosis, again suggesting or contributing to the observation that the myeloid component is driving an immunosuppressive phenotype and limiting anti-tumor immune responses here. We see similar curves breaking down the myeloid cells with a tumor supportive versus tumor anti-tumor phenotype, and the tumor supportive phenotype being the M2, what we used to refer to as M1 versus M2, but those that are more pro-tumorigenic immunosuppressive, more of an M2 phenotype, when there's a higher percentage of those, patients do worse as well. So a lot of interest now in understanding these myeloid cells and then being able to target them therapeutically is beginning to evolve. We've got a very long way to go, but some very preliminary strategies that are currently being put in place in the clinic to use therapies that can block the recruitment of these tumor-associated macrophages from the bone marrow, interrupt or help reprogram them from being immunosuppressive to being anti-tumor, augmenting their phagocytosis, their normal physiologic role, which is downregulated typically in tumor biology, and then therapeutic strategies to target and eliminate specific subpopulations of these myeloid cells. I don't have time today to go into the different strategies, but I think it's important when we think about immunotherapy approaches to keep in mind that we do have this additional hurdle to overcome, and probably at some point going to need to be thinking about combinatorial strategies focusing on the myeloid component as well as strategies driving immune cells into the tumor. But I think that's not going to be quite so straightforward. This is a single-cell RNA-seq profiling of myeloid cells isolated from glioblastoma tumors, and highlighting here pretty significant heterogeneity of these cells from a gene expression analyses with at least 6 major subtypes identified within the population of TAMs within glioblastoma tumors. So there probably won't be one magic bullet to be able to treat and eliminate or control these cells based on this type of heterogeneity. But now to shift gears and talk about an update of cellular therapies for glioblastoma, the solid tumor refractory to immunotherapy. First, I want to talk about CAR T cells, and we've heard much at this meeting of the really elegant and exciting work that's ongoing, again, transforming how we treat many cancers and malignancies, particularly hematologic malignancies, but more challenging in the solid tumor space. And we got very excited with this initial report from Christine Brown and Benham Bodi's group at the City of Hope in California, where they developed an IL-13 receptor 2 alpha CAR and treated this one patient reported in the New England Journal of Medicine with multiple infusions of CAR T cell therapy. The patient had multifocal disease throughout the brain as well as in the leptomeningeal space up and down the spinal cord, and with local regional delivery of these CAR T cells over multiple injections, were able to eradicate the disease. And this patient lived 14 months, and when the disease recurred, it was IL-13 receptor 2 alpha negative, eliminating that, demonstrating the CAR T had been able to eliminate the clone associated with the target. They recently published an update of their work with this particular monovalent CAR T cell approach targeting IL-13 receptor 2 alpha. This is the largest series of CAR T cell therapy reported amongst malignant glioma patients to date, 57 patients, getting multiple injections local, regionally, into the CNS of the CAR T cell product. And they did report these were, in general, fairly heavily pretreated patients, and some of them were my patients, actually, I sent to them, with often bulky, very challenging disease, and they reported some modest median overall survival in this context. There are challenges with these approaches in this disease, and one of them being, one of the key ones being the heterogeneity of these cells, like in other solid tumors. The target often is present within a subset, and difficult to define what may be an optimal target going forward. if there is a single target that's optimal to have a meaningful therapeutic effect. So more recent efforts are focusing on multiple targets with the cellular therapy approach, and two of them are recently reported. This is work from our colleagues across town in Boston at Massachusetts General Hospital, Brian Choi and Marcella Moss, where they developed an EGFR V3 targeting CAR, but when it binds to its target, the CAR expresses an EGFR targeting CD3 BiTE. So it allows the interaction of the CAR T cells with both EGFR V3 and EGFR positive tumor cells, so a higher prevalence of target. And they had encouraging activity in preclinical models and recently reported in the New England Journal very preliminary results of 3 patients treated local regionally with the infusion of the CAR T cell product. And one of these patients doing well out over 5 months at the time of the report with a significant radiographic response of disease. Another approach targeting multiple targets within the tumor comes from the group at the University of Pennsylvania in Philadelphia in the U.S., led by Don O'Rourke and Steve Bagley, pictured here. There are different bivalent CAR approaches. One approach is to use a tandem CAR where you can engineer the CAR to hit 2 different targets in tandem. They actually went with the alternative approach called a bicistronic CAR that had separate engagement and binding capability for both EGFR and IL-13 receptor 2 alpha. This was reported in Nature Medicine earlier this year, and these were more typical recurrent glioblastoma patients that they treated, multiple lines of prior therapy typically, and patients with bulky disease, like this patient where you can see multifocal disease that did respond, again, with local regional injection of the CAR T cell product over time. So these results are encouraging, quite preliminary, of course, but rather than focusing on identifying a particular target and trying to exploit that, might there be an approach where we could utilize cellular therapies capable of intrinsically hitting multiple targets within the tumor, and hence the potential for tumor-infiltrating lymphocytes, and that's what I'm going to finish and talk with about here. We know from work published many years ago that tumors, higher TIL content within a tumor has been associated with improved overall survival, and the thinking being many of these cells are enriched for tumor-reactive T cells, but we now know only a minority of them actually are. The strategy here for isolating and expanding TILs from a given tumor, summarized here for those who are not familiar with the process, but these TILs can be isolated and then rapidly expanded ex vivo and then infused back into the patient. And this was work pioneered by Steve Rosenberg and others in metastatic melanoma, and these were PD-1 refractory patients where he demonstrated a over 50% response rate with TIL therapy and a durability with this impressive tail of the curve demonstrated in this initial report that he put together from his series of treated patients. A phase 2 study relatively recently published with a commercialization of this approach with lifileucel, again in recurrent melanoma patients who were refractory to PD-1 primarily, showing pretty encouraging responses both in the waterfall and swimmer's plots. And then this approach was granted FDA approval in the United States. I don't know if it's approved in Europe or not. But it's approved in the U.S. based on this randomized phase 3 study that was again published recently, again in primarily PD-1 refractory patients randomized to get either CTLA-4 blockade or TIL therapy, and the patients who received the TIL therapy having significantly prolonged progression-free survival and enhanced overall survival and greater reduction of tumor burden. So what about the application in other solid tumors? And my interest, as mentioned, is in malignant glioma. So there's really only been one TIL therapy study published for malignant glioma, and that's in the top row here. This was 6 patients who, back in 1999, were reported a couple of other studies showing systemically collected and expanded lymphocyte populations administered intratumorally for glioblastoma patients reported here, but small series and many years ago, the last this was done. So we thought this might be an appropriate approach to consider for our patients, and in collaboration with colleagues here from Miltenyi, we've moved forward with a proposal for a phase 1 study of autologous CD137 enriched TILs plus recombinant human IL-2 with and without systemic anti-PD-1 therapy for patients at first recurrence of glioblastoma. Again, the schema very similar to what I showed before, collecting the TILs at the time of tumor resection, identifying the CD137 positive TILs, rapidly expanding them, and then administering them locally, regionally to patients, along with recombinant human IL-2. Why CD137 enrichment? This is a marker identifying T cells that are more likely reactive and expressing an anti-tumor or demonstrating an anti-tumor phenotype. So identifying and selecting this population would theoretically enrich for a greater likelihood of an anti-tumor effect, and there is preclinical data to support the use of these in other cancer types. So we have the capability, again, with the technology developed here at Miltenyi for being able to separate out TILs from glioblastoma tumors, either fresh tumors or tumors collected directly from the operating room, and then utilizing the technology to expand these and administer them back to patients, or expanding them and then freezing them down for later administration for patients. So we're proposing a very straightforward, simple study of patients at first recurrence. There'll be 2 cohorts of patients. Cohort A will get the TIL product plus human recombinant IL-2 injected into a surgical resection cavity. We'll have a small dose expansion if the MTD or recommended phase 2 is not exceeded. And then if this shows adequate feasibility and safety, we would move on to cohort B, where we would combine the product with an anti-PD-1 therapy. And this is going to be performed at a single site in Boston at our institution. Primary objectives here are safety and feasibility, of course. And we hope to be able to identify potential correlatives associated with a primary tumor that may help predict patients who are more likely to benefit or have this feasibly done. Based on the limited work in the literature and some of the data from CAR T-cell approaches, we've planned to do somewhat empirically dose levels of the TIL product plus human recombinant IL-2 with a de-escalation if the MTD is exceeded for both cohorts A and B. We're going to use a simple 3+3 design to determine the MTD recommended phase 2 and then do a small dose expansion at each cohort of patients. And very importantly, we want to take a deep dive into the baseline tumor that's acquired at the time of resection. And then when patients develop evidence of potential progression later on in the course of disease, we have a strong effort to have those patients go back to surgery and collect the material at that time and subject both the primary tumor as well as the tumor at potential recurrence, so paired tumor samples for detailed analysis of multiple aspects identifying features associated with immune activation triggered by the TIL product. So to conclude, glioblastoma and other immunotherapy refractory tumors, typically characterized by myriad and redundant mechanisms of immunosuppression. These are immunologically cold tumors with inherent low tumor immunogenicity, and in many of these tumors, a dominant suppressive myeloid component. Strategies to drive T cells into the tumor microenvironment certainly are very compelling, CAR T cell approaches and TIL therapy, but I think future efforts need to continue to prioritize better understanding the microenvironment and ultimately being able to combine these therapies with treatments to downregulate or diminish some of the suppressive effect of the myeloid population. So I'd like to conclude by acknowledging the many members of our team I have the privilege of working with on a daily basis. Thanks to a group here at Miltenyi and our cell manipulation core facility at the Dana-Farber, and our sources of funding support. Thank you very much.
Thank you, Professor Reardon, for such an interesting presentation. Now we have some time for questions. Please approach the microphone or raise your hand to get the microphone. Go ahead, Misty.
Thank you, David. Beautiful presentation as always. I completely agree that the overcoming immunosuppression of the myeloid compartment in GBM is going to be really critically key. I wondered if you could expand on some of your and others' strategies to do this, either through armoured cars or other small molecules, and in specifically related to what other sort of subtypes you think are going to be the most pertinent to either suppress or remove or augment.
Yeah, that's kind of the holy grail I think we need to hit, Misty, is to be able to come up with a therapy. I don't think we necessarily need to eliminate these myeloid cells. I think we basically need to be able to administer a therapy that can reprogram them to become more like their natural state, to be able to phagocytize and to function as normal macrophages and myeloid cells in the microenvironment. So there are a variety of different strategies trying to, as I mentioned on that one slide, that are moving into the clinic, and there are clinical trials now looking at molecules that can block the factors that drive the myeloid cell trafficking from the bone marrow into the microenvironment, factors that can help try to flip them from being, these are mostly cytokine kind of molecules or treatments that can try to flip their phenotype from being immunosuppressive to being immunosupportive. And then molecules developed, colleagues from MD Anderson are working on strategies to try to help improve their capability of their inherent phagocytic capability to restore some of their natural function. I think it's going to be a very tough challenge, frankly, and may take a variety of different approaches to be able to overcome that population within the microenvironment, though.
Right. Really nice talk. Thank you. I have two questions. First of all, the microenvironment in the glioblastoma setting, do we need to stratify? I mean, is it the same in each type, or do we have to consider that there are also differences in the microenvironment between different sort of glioblastoma subtypes? And the second question is in relation to the 137 enriched TILs. Can you comment on if they're actually recognizing killing primary glioblastoma samples, and do you have any ideas on the specificity of these TILs?
So the first question, trying to, I'm sorry, better.
So is it like a homogeneous? Is it always the same the microenvironment? I mean, I think there were reports that there are differences also in the microenvironment between different subtypes.
Yes, yeah. So gene expression profiling of glioblastoma tumors has identified at least 3 versus 4 different subtypes, and they do seem to have differences amongst those subtypes in the tumor microenvironment. Different factors associated with the myeloid component, as well as different percentages of immune-infiltrating lymphocytes in those different subsets. So yes, there is heterogeneity amongst glioblastoma tumors of the microenvironment, but I think there is, across the subtypes, still a dominance of myeloid cells that will be important to consider and ultimately treat, and a relative paucity of immune effector cells in the microenvironment. So across the different subtypes, yes, there'll likely be some differences that may need to be taken into account for different therapeutic approaches. But I think nonetheless, the approaches still will likely be relevant across those tumor types, driving more immune effector cells in decreasing the suppressive component. And the second, I'm sorry, the second.
The 137 enriched TILs.
Oh yes, the CD137 positive. Whether they truly are capable of killing the GBM tumor cells. I hope people had a chance to see Irina's poster from here last night that was out, but she has some very elegant preliminary work that is supporting our trial here, showing in glioblastoma tumors directly from the operating room from patients' ability to isolate these cells and expand them and then demonstrate true tumor cell killing in cultures subsequently.
And do you know any about the specificity of these TILs?
I don't, but I defer if she is here to comment. No, Andres is here. No, not yet.
Thank you.
Stay tuned.
No. Hello, Remy Caleta, Miltenyi, biomedicine. I have a question regarding CD137 activating T cells through priming by radiotherapy. You know, there were some clinical works from MD Anderson, namely James Welch, presenting this type of very extensive activation of T cells. Do you, since GBM glioblastoma is also very often treated with radiotherapy, do you think that this may be approach for exploring, or you plan to do that?
So yes, all of these patients will have had prior radiation therapy and then have progressed. So they are considered radiation refractory patient population. I think this certainly would be very appropriate to move up front into newly diagnosed patients where it could potentially be teamed in with standard of care therapy, including radiation therapy. But we know the cytotoxic therapies, radiation included, can also upregulate expression of a number of the suppressive molecules in the tumor microenvironment, contributing further to immunosuppression as well. So I think we'll need, again, better understanding and being able to target some of those factors effectively. And we hope we don't see, I think CD137, this is the first step, obviously. It makes sense to see, but there may be better markers down the road that we want to think about or to consider in the next generation.
Thank you.
Very nice overview. To which extent have people used or tried to block myeloid cell recruitment using chemokine receptor inhibitors?
There's preclinical work and ongoing clinical work, so very early clinical strategies with those therapies.